I would like to thank the organizing committee for the honoring invitation to be able to discuss with you today the role of active surveillance in this specific subgroup of patients, not the low-risk patients, but what we call intermediate-risk patients. And I will start with the goal of prostate cancer screening. That should be to identify cancers that may one day impact the patient's quality and quantity of life. However, if we routinely treat those low-risk prostate cancer patients, then we are certainly going to have an impact on the quality of life without any demonstrable effect and benefit in the quantity of their life. So, for this reason, active surveillance is now considered the standard of care for low-risk prostate cancer. As you can see in a recent editorial in the Journal of Urology, it's the much preferred treatment for low-risk prostate cancer, and this recommendation has been adopted by actually by all the international guidelines. But let's start with why go for active surveillance. The reason the active surveillance is so popular, and we're trying to actually make it popular and attractive, has to do with a risk of complications related to treatment. So if any treatment was without any side effects, then we have no problem treating all patients. But this is not true, as you all know. We have evidence, and this is the best evidence available, on the side effects of treatment. This paper I think it's from 2013, with a very large group of patients with prostate cancer. Half of them were treated with either surgery or external beam radiation therapy. And as you can see in the graph, urinary function, sexual function, and bowel function have all declined in both groups, radiotherapy and radical prostatectomy group, compared to patients who received no treatment. However, active surveillance is not ideal for all patients with low-risk prostate cancer. There is a small cohort of patients, around below 20%, with low-risk prostate cancer who should probably consider primary treatment to start with. So this group might probably includes very high volume disease in a younger patient, patients with a strong family history of lethal prostate cancer, patients who have adverse genomic or imaging tests, and of course the rare patient who has a very high level of anxiety and he's not happy to continue his life with a diagnosis of prostate cancer. This also includes patients who are not happy or it's impossible for them to adhere to any routine surveillance protocol. So, active surveillance, the rates of adoption of active surveillance have increased during the last 10 to 15 years, as you can see, from 10% to around 50%, and this is mostly USA data, and it has gone up to 80% for low-risk prostate cancer in Sweden and also in the Veterans Affairs health system in the USA. So this adoption is actually increasing over time for low-risk prostate cancer. However, it is important to actually tell to the patient or reassure the patient that even if he opts for active surveillance, he has the option at any time to change to shift to active treatment, and this will have no impact on his long-term prognosis. The patient will remain within this, what we call window of opportunity. And of course, as you can see from the graph to the right, it is important to tell the patient that there is an almost 50% chance that at some point the patient will need to have some form of active treatment. As you can see here, the rate is around 50% after 6 to 8 years on active surveillance. So 1 out of 2 patients will at some point need to have treatment, or he will be offered treatment. So what about active surveillance in the intermediate risk prostate cancer group? Let's start with the definition. So the intermediate risk group should have at least one of the following: T2B or T2C clinical staging, Gleason score of 7, and a PSA above 10 and below 20. This is, as you know, a very large and heterogeneous group of patients. And this, according to the NCCN guidelines, has been subclassified to 2 groups. What is called the favorable intermediate risk group. Patients in this group should have at least 1 intermediate risk factor and a Gleason score of 3 + 4 = 7 or less, and less than 50% involvement in prostate cancer, with prostate cancer in biopsy course. Whereas there is the unfavorable intermediate risk group, where patients have more than 1 factor and a Gleason score of 4 + 3 = 7, and more than 50% involvement of cancer in the prostate biopsy. And the reason I chose green is because those patients can be selected or can be advised to go for active surveillance, whereas for patients in this group, they're taking a rather increased risk of failure, as we'll see later on. So, as I mentioned previously, recommendations for active surveillance for patients in the intermediate risk group have been adopted by most of the guidelines, actually by all guidelines. The difference is that the European guidelines and the Canadian guidelines, they limit those patients, the suggestion to patients who have low volume grade group 2 disease defined as less than 10% involvement of Gleason pattern 4. Whereas the NCCN guidelines do not have this recommendation, this limitation actually. So, what about the adoption of active surveillance in this specific group? As you can see, it's rather small, and this is more or less expected. In the USA, the rate of adoption of active surveillance for this intermediate risk group is around 10%, and again, in Sweden, it might go up around to 20%. And there are some things we need to consider before counseling a patient pro or against active surveillance, again, in the intermediate risk group. I have two, let's say, most common patient scenarios. The patient with a small amount of Gleason 4, so a patient with a Gleason 3 plus 4 equals 7, and a small amount of pattern 4. And the other case is a case of Gleason 3 plus 3 equals 6, with a PSA more than 10, which by definition makes this patient, actually classifies this patient as intermediate risk. In most of these cases, the PSA is above 10 because of a large prostate. So studies have shown that the former group, this patient has a higher risk of failure on active surveillance compared to the patient who has a Gleason 6 with a rather increased PSA. Other things to consider in this intermediate risk group is the histologic subtype of the tumor. As you all know, the cribriform pattern in histology harbors more aggressive disease, and the prognosis is not as good as for patients who have no cribriform histology. And another thing related to that is the fact that sometimes cribriform pathology is not shown on doesn't show on MRI scans. And another issue to consider is the presence of genetic mutations, especially the presence of a BRCA2. Those patients do not do well on active surveillance, and at some point they have an increased risk of needing active treatment. So let's look at this in more detail. As you can see in this graph, we have the risk of metastasis and mortality in men with low and intermediate risk prostate cancer. This is the largest study available of more than 1,000 patients. 10% of them belong to the intermediate risk group. As you can see, most of them belong to the favorable risk group. Within a median follow-up of 7.6 years, the prostate cancer-specific mortality at 10 years was estimated at 1.1 for the low-risk group, 3.7% for the favorable intermediate risk, and it went up to 12% for the unfavorable intermediate risk group. As you can see in the graph, this is the rate, the risk of metastasis, this is the risk of death. The difference is, of course, statistically significant. As you can see, there's a four-fold increase in the risk of failure of active surveillance for patients in the unfavorable intermediate risk group. Could MRI be of help? Can we rely on MRI to tell us which patient should stay on active surveillance? Studies have shown that this is not a very good idea. MRI is very helpful, but it's not a holy grail. As you can see in this presentation, with 207 patients on active surveillance with serial MRIs and biopsies, 1 out of 3 men with stable MRI findings was upgraded to Gleason grade 2. So the MRI, let's say, loses 1 out of 3 patients. And in those cases who haven't had a biopsy, the patient will still remain on active surveillance as low risk, whereas actually he was intermediate risk. Again, is MRI helpful in finding out, discriminating between visible and non-visible disease? This is a very nice recent study in European Urology looking at exactly this, whether the visibility of a lesion on MRI changes the prognosis. As you can see here, on the left we have the event-free survival. On the right there is the time to prostate cancer treatment. What is important is the colors. With orange and red are the patients who do not have visible disease on the MRI scan, whereas with green and blue, we have patients with visible disease on MRI scan. As you can see here, the risk and the rate, actually the percentage of patients needing treatment is very low. It's lower, actually, for patients who do not have a visible lesion on the MRI scan. Can we help in predicting which patients will fail or progress on active surveillance? Recently, there has been a publication from the Canary Pass study, and they have developed some algorithms which are very helpful. You can find them easily on the internet. There is a risk calculator. They have developed a risk calculator for patients who are already on active surveillance, looking at the risk of progression within the years to come. As you can see, this nomogram or calculator takes into account different patient parameters like the PSA, the BMI, the age of the patient, the percentage of cores involved in the previous biopsies, and it gives you a percentage. In this case, it is, I believe, 17%. So this patient has a 70% chance of upgrading to grade group 2 in the next biopsy or the next years of follow-up on active surveillance. What else can we do to help those patients not progress on active surveillance? There are studies showing that some what we call lifestyle modifications might be of benefit, like cessation of smoking, reducing the intake of red meat. And there have been a couple of studies showing that physical activity and high-intensity interval training are also beneficial for those patients in order not to progress to a more invasive disease. Aggressive disease. There are also a couple of studies showing that metformin and vitamin D might also be of help in this patient in order to reduce the risk of progression to more advanced disease. Recently, there have been biomarkers introduced in the follow-up, in the monitoring actually for patients on active surveillance. Those 4 biomarkers have been approved, and as you can see in this slide, they have been approved by the NCCN for low or favorable intermediate risk patients in order to have more information and more data and counsel your patients whether or not it is safe to continue on active surveillance. And we'll close with the monitoring of patients on active surveillance. As you will notice in the guidelines just offer a recommendation on the maximum amount of testing that should be done in individual patients, but this should be actually customized and should be risk adapted because not all patients are the same. We should not have the same strict follow-up for low-risk disease and for intermediate-risk disease, so this will need to be individualized. And I will conclude trying to answer the question. I believe that for favorable intermediate-risk group patients, especially those with an elevated PSA above 10 and a Gleason score of 6, it is safe to stay, or it is safe to actually propose the patient to go for active surveillance. The same will apply for low volume 3+4 disease, whereas for the unfavorable intermediate risk group, the risk that the patient takes going for active surveillance, I believe, is substantial. As you noticed earlier, there's a fourfold increase in the risk of active surveillance failure. However, if the patient is persuaded, then he will need to adhere to a very stringent protocol involving molecular testing, MRI, restaging prostate biopsy, which is very important, surveillance MRI, and surveillance prostate biopsies. Also, it is important, and I believe this should be incorporated in our clinical practice, to use risk assessment tools, especially the PASS risk assessment, which is, as I mentioned previously, available on the internet. Thank you for your attention.